The decision when to give chemotherapy in a hormone receptor positive case hinges on a few different things as well. So one of the things we look at initially is if we get a woman who presents with metastatic disease and she's hormone receptor positive, commonly we'll look at the disease burden. So we'll look to see if she has any kind of significant visceral involvement. And if she does have enough disease in her organs that we're concerned about impending organ failure, then often we can start with chemotherapy. And then once we get done with the initial treatment of chemo and her disease is under control, then we can revert back to giving her a chemo-free holiday and then initiating an appropriate line of endocrine therapy. So that's one strategy that's commonly used in the clinic. If a woman has bone-only disease or minimal visceral involvement and she's relatively asymptomatic from her disease, often we'll start out with endocrine therapy because that's better tolerated than chemo. And we'll keep treating her with different lines of endocrine therapy until she essentially shows no further benefit from hormonal therapy. And then at that point, she'll get switched over to chemotherapy. And that's generally inevitable in most of these women with metastatic ER-positive breast cancer. The difference is in that some women can go a long time before they have to go to chemotherapy. Others, they have a very short time before they require chemotherapy. And that's more of a reflection of the biology, the disease, and how inherently resistant they are to hormonal therapies.